Hi, my name is Carly, and this is my Case Connections to video presentation. So I decided to choose Case 3 and Case 4. So I'm going to talk to you a little bit about that. I'm going to explain to you my answer choices, and I'm going to explain to you why I didn't pick some of the other answer choices that are present. So we'll start off with Case 3, and then I'll move on to Case 4. Okay, so case number 3 is a 5-year-old boy who is brought to the pediatrician's office for an annual visit. The mother reports that he has been a sickly infant and appears drowsy. She also has other concerns of patient's persistent thirst and frequent urination, and blood samples are taken, and insulin measurements are started at time 0, so the initial presentation of the patient, and then an hour after the glucose loading test. And then the results are in the table here below. So at baseline, you can see that the patient has serum insulin levels, not glucose levels here, right? Insulin levels of 0.8. And the control group has baseline samples of insulin to be, or fasted, you would assume, levels of insulin to be between 4 and 8. So 6 plus or minus 2. So you can already see that there's a difference there on the glucose levels in the patient versus the control group. Then you can see an hour after glucose load, so an hour after the patient has eaten something, probably, or maybe drank apple juice or something that has glucose, sugar. The patient's insulin levels, serum insulin levels here are 5, and the control group is 40 plus or minus 11, so 29 to 51. So that is a very big difference in the insulin levels in the patient versus the insulin levels in the control group. So what is this information likely to suggest about the patient? So I think that, first of all, his presentation of his symptoms, he's a 5-year-old, so he's a young person. He is having increased thirst and increased urination. Those symptoms right off the bat are likely for me to believe that he has diabetes. And then we look at these insulin levels and we're thinking, okay, so he has insulin-dependent diabetes because his insulin levels are so much lower than the control group. So his pancreas is obviously not able to secrete enough insulin for his body. And those are classic and very common symptoms of insulin-dependent diabetes. So if he was a normal, or not a normal diabetic, but a type 2 diabetic, so someone who wasn't insulin dependent, you wouldn't really see this massive change and decrease in insulin. Because the insulin is still there, it's just really not able to do its job correctly. So I would predict for the fasted glucose levels, given in this patient's current condition, I would expect them to be well above the normal range. That would be normal levels of anyone. So say we are 100 right now, normal. I expect this patient to be in about maybe the 400s. If they eat food not fasted levels, obviously this would be a little bit different. It would be a little bit lower, but they're still not able to convert this glucose in their blood into energy because they're lacking this insulin. So their blood glucose levels are going to be a lot higher than the control group. And then 2 regulatory enzymes that I chose that would be active in this individual's current condition would be glucose 6-phosphate and phosphofructose kinase. And that is because these are active in the GNG pathway, and they would still be active in this patient. However, they just wouldn't be as active as it would be if the patient was secreting regular levels of insulin. So this glyconeogenic pathway would still be present, but it just would not be as active. So these enzymes would still be there. Okay, so moving on to case 4. So case 4 is a previously healthy 2-month-old female, presents with jittery spells several hours after breastfeeding. Her mother reports that she's not given the baby anything to eat other than breast milk since birth, so she's only taking in breast milk. The baby has recently been sleeping for more than 2 hours between feedings, and that's when the mother reports these symptoms started. Lab results are consistent with hypoglycemia, but are otherwise unremarkable in this patient. Epinephrine is administered, and there was no increase in blood glucose, but there was an increase in blood lactate. Upon physical exam, there's noted hepatomegaly, and blood glucose levels increase after breastfeeding, but she cannot maintain the glucose levels within a normal range during fasting. So after she's been fed, she can't keep her blood glucose levels up. So based off this information, based off the exam clinically and the presentation, I think that glycogen storage disease is most likely the diagnosis for this 2-year-old patient. So again, like I said, I think that is because, number one, the physical exam presentation, hepatomegaly and jittery spells or muscle cramping and hypoglycemia are all clinical presentation and physical exam findings of patients who present with this disease. And furthermore, due to the fact that when epinephrine was given, but there was no increase in the blood glucose, but there was an increase in lactic, also made me believe that this was the reason that the glycogen storage disease was the answer to this question. Normally when epinephrine is released into the bloodstream, it causes the liver to convert the stored up glycogen to glucose, which would then in turn raise glucose levels. But if there's a problem with the storage, then there would be nothing to convert to glucose to raise blood glucose levels. It also makes sense to me here with the jittery spells, if I'm thinking like a clinical presentation of this. So normally, after you eat, you have a little bit more energy. So it would make sense to me that they're having these jittery spells because they can't store anything. So the body is having this release, this rapid releases of all of this energy. So it makes sense to me that the baby would get very, very jittery because they have all this energy that's building up in their body and there's nowhere to store it. So after fasting, that they're, lethargic, can't hold blood glucose levels, also makes me believe that there is a problem here in the storage of the glucose, because normally in fasting, that's, during the normal part of the synthesis, there's a place to store the glucose. And here, there does not seem to be a place to store the glucose. So the reason that it is not these other diagnoses. So hereditary fructose intolerance is when a patient is having intolerance to the fructose that they are ingesting. So this would be in the pathway, and there would be a mutation in aldolase B, which cleaves fructose, which is seen in fructose metabolism. These patients would present clinically with nausea and vomiting and some iron deficiency, so the patient could possibly be anemic on lab work. And this diagnosis does not make sense here because the mother is giving the child only breast milk, and fructose is not present in breast milk here. So this answer would not make sense to me. So galactosemia. So I think that this answer is not correct because this is when the body is not able to convert galactose. So that is what is present in breast milk. So we know that could be an option, right? This is the one that I was kind of wavering the most between the two. But this is present in the milk, and then it converts galactose to sugar because this occurs when the GALT enzyme is blocked. And this is usually very toxic to the kidneys and the central nervous system. But the determining factor here that changed my mind was that giving the patient epinephrine in this case would not cause the lactic amount in the blood to raise. This level would not raise. It would stay the same. And so this is the reason I did not choose this answer. And then finally, having a glucose 6-phosphate dehydrogenase deficiency. So these symptoms, again, clinically present with some tachycardic mania, some palpitations, so jaundice, so yellowing the skin, maybe some scleral icterus, some yellowing of the eyes, which usually correlates with jaundice. Fever, dizziness, and dark-colored urine. Obviously not all of these symptoms, but these are just a few that I found. So during this deficiency, there would be an inadequate supply of NADPH. And if there's a low supply of NADPH, then there are also reduced levels of glutathione, which is what is protecting the oxidation of the blood. So clinically, I would suspect that these symptoms don't correlate, right, with the symptoms of this 2-month-old that is present here as well. And this pathway, the glucose 6-phosphate dehydrogenase deficiency, also targets red blood cells, right? Because we're not protecting the oxidation of the blood anymore. So the lactic in this case would make sense to be elevated because maybe there's some lactic acidosis in the blood. But I would also be thinking that this would be targeting maybe some red blood cells more and destruction of red blood cells, which would be released into the bloodstream. So this patient may also be anemic on blood work. Maybe they would have decrease in red blood cells based off this deficiency because there's none protecting them anymore. Okay, so this is the end of my case 2 presentation video, and thank you for listening.